to all the dignitaries assembled over here and all the lovely audience. Today's topic of my presentation is varied clinical presentation of allergy and experience from our ChanRe Rheumatology and Immunology Center. To begin with the introductory slides, I would like to give a gist about allergy as well as autoimmunity in the introduction. Allergy is a broad topic and it is defined as an abnormal response, a hypersensitive reaction initiated by various immunological mechanisms when exposed to an allergen either through ingestion, inhalation or skin contact. Allergies of various clinical forms affect more than 30 to 50% of the given population at any given point of time. Most of the commonest allergens are food allergens, plant allergens, insect stings, as well as drugs. How is this allergy manifested? The allergy is a multi-organ system involved disease. It manifests as itchy eyes and red eyes. When it comes to eyes, it is termed as allergic conjunctivitis, and it also presents as running nose, wheezing, cough, etc. when it affects the respiratory system. And here the term given is allergic rhinitis and allergic bronchitis. And it also presents as skin rashes with itching, allergic dermatitis. It has presentation of swelling of lips, tongue, airway. It also affects the gastrointestinal tract, landing the patients into nausea, vomiting, abdominal cramps, diarrhea when they consume certain type of foods, and it also can cause syncope as well as collapse. Here, the disease mechanism basically involves the mast cell degranulation, contributing to the secretion of histamine and various other chemical mediators which are responsible for the majority of the symptoms which I have described just now. So these are the two pioneers coming from his clinical research field in the field of infectiology and immunology. A Viennese pediatrician, Sir Clemens von Perket, was the person who termed allergy in the year 1906. And autoimmunity is the immune response against self. It evokes the specter of horror autotoxicus, literally the horror of self-toxicity, a term which was coined by Professor Paul Ehrlich in the late 19th century. So these were the two pioneers who coined the term allergy as well as autoimmunity. To tell you a brief introduction about autoimmunity, autoimmunity is an aberration in the body's normal development such that the immune system mounts an attack against its own cells. The etiology here is multifactorial. It can be genetic, it can be hormonal, it can be environmental, and all these factors together also can play a role in causing autoimmune diseases. Any malfunction of the immune system occurs in three main conditions. One is allergy, the next one is autoimmune disease, and the third one is immunodeficiency. Here, let me make it clear in simple language to all of you that allergy basically is the reaction of the body to an external protein, whereas autoimmunity is the reaction of the body to an internal protein or the self protein within the body. So here we have series of cases. I have 4 cases to present from our hospital. Let me begin with the case presentations. To begin with the first case, he was a 19-year-old boy hailing from Vijayawada who came with complaints of papular rashes and itching all over the body, including scalp as well as face since 5 months. He also had recurrent episodes of sneezing since 1 month. There was no history of other allergic symptoms like wheezing, cough, eye symptoms, fever, etc. A significant history was he gave history of weight loss of 9 kgs in an year, and he also complained of generalized weakness of late. He was a second-year engineering student. He also gave history of allergy to gluten as well as peanuts. Coming to his personal history, he was a vegetarian with normal appetite, bowel, bladder habits, except for his sleep disturbances since 1.5 years. Treatment-wise, he was given antihistamines, oral steroids, antihelminthics, and he had applied diprovate ointment for his skin lesions. Coming to his general physical examination, his respiratory system, cardiovascular system, central nervous system, and para-abdominal examination was completely normal, except for his skin rashes which was present on the bilateral upper, lower limbs as well as back and face. Moving on further, he had come to us with a set of investigations which I have mentioned here. I have highlighted the abnormal values only. Here, the total count was on the higher side, that is 15,350. The platelet count also was on the higher side, 5.74 lakhs. ESR was high, 95. Absolute eosinophil count was high, 1050. And the CRP also was high, that is 40.3. He had done few other tests like ANA, ANCA, antimitochondrial antibody. All these were negative. The serum IgE levels was abnormally high. It was 3,128 when compared to the normal range, which should be below 100 international units. The viral markers were also negative. The peripheral smear showed normocytic normochromic blood picture with neutrophilia. His COVID test was negative. He had done MRI cervical spine which was normal. Endoscopy had showed candida esophagitis as well as the biopsy showed Helicobacter pylori infection for which he was treated. His colonoscopy was normal. His ultrasound abdomen showed gallbladder polyps. With these symptoms in mind and the set of investigations he came to us, we had made a provisional diagnosis of allergic diathesis. Moving on further, when we investigated him, our in-house investigations gave this picture. Here, there was still persistent leukocytosis, that is the total count was still even more on the higher side, that is 20,490. The neutrophils were slightly high, 82%. There was a dip in the lymphocytes, 6.1%. ESR and CRP, both the inflammatory markers were persistently high. That was, ESR was 68, CRP was 101, and the platelet count was marginally high, 4.61 lakhs. Since his IgE levels were high, we went ahead doing an allergy panel, and the allergy panel showed borderline sensitivity to wheat as well as mustard. And all his immunoglobulin levels, IgG, IgM, IgA, IgG4 antibodies were within the normal limits. Now, since he gave a history of weight loss of 9 kgs in 1 month, as well as he had fatigue presentation, we thought of doing a chest X-ray also. Moving on further, we did a chest X-ray, and surprisingly, chest X-ray showed us this picture. So here, there was a mass in the mediastinum, and further when we subjected him to HRCT thorax, there was a confirmed anterior mediastinal mass which suggested it could be probably the thymoma or the germ cell tumor. Patient was referred to cardiothoracic surgeon oncology unit for further evaluation and treatment. When I tried following up with the patient, he had undergone biopsy of the mediastinal mass as well as PET scan, which finally confirmed the diagnosis of hematolymphoid neoplasm, that is Hodgkin's lymphoma. He was given chemotherapy sessions at Manipal Hospital, Bangalore, and at present the patient is stable and he is doing fine. So this was the first case which presented as allergy but turned out to be a neoplasm. Moving on to the second case. Here is a 32-year-old female who came from Ballari, and she came with a history of urticarial rashes all over the body associated with itching. She correlated these episodes more so to the episodes of fever, and especially when she took medicines for fever. There was absolutely no history of recurrent sneezing, wheezing, cough or any other eye symptoms which led to allergic symptoms. By profession, she was a nurse in the health department. Her personal history-wise, she was an vegetarian with normal appetite, bowel, bladder habits. She had little sleep disturbances past 3 to 4 years. Her obstetric history, she had regular menstrual cycles, married life of 12 years, para 2, living 2. Both deliveries were full-term normal deliveries, and she was tubectomized. Treatment-wise, she had taken antihistamines and steroids. Her general physical examination was completely normal. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy or edema. Her vitals were completely stable. Systemic examination was also normal. She had come with the investigations, that is, she had done complete blood count outside, and it was completely normal. So with this picture in mind, we thought the provisional diagnosis would be urticaria for further evaluation. Moving on further, when we subjected her to investigations in our hospital, her ESR was slightly high, that is 43. Her ANA was positive, that is 1+. Her complement levels were normal. Serum IgE level was on the higher side, 355. Since her IgE levels was high, we did an allergy test. Allergy panel was completely negative. As her ANA was positive, we went ahead doing the autoantibody profile test, that is Quantrix 24. There it showed few of these autoantibodies which was positive. That is RNP Smith was 1+, Smith was borderline positive, and PCNA also was borderline positive, along with AMA-M2 which was 2+. Since these autoantibodies were positive, we did a chest X-ray as well as pulmonary function test, which was completely normal. We evaluated her eyes as well. The complete ophthalmological examination was normal. So with this picture in mind, we thought probably the rashes could be due to the connective tissue disease, and hence we made a final diagnosis of undifferentiated connective tissue disease, and she was treated with antihistamines, hydroxychloroquine, and she has had 2 follow-ups so far, and she is asymptomatic till date, and her IgE levels also have come down to 85. So this was the second case which was thought to be allergy, but finally the diagnosis turned out to be an autoimmune disease, probably undifferentiated connective tissue disease. Moving on to the third case scenario, a 40-year-old male presented with multiple joints pain since 6 months associated with swelling. There was no early morning stiffness. The large as well as the small joints were involved along with myalgia. There was no history of back pain. He correlated this particular increase in pain when he ate certain type of food, especially non-veg items, but he was not sure because he was eating non-veg since very long time. And he was from Hassan, and he was working in a private company as a supervisor. Personal history-wise, he was a non-vegetarian with normal appetite, bowel bladder habits, with good sleep. He was a non-smoker and non-alcoholic. General physical examination was completely normal except for little swelling over the hands. Vitals were stable. Systemic examination was normal. Joints examination, bilateral hand joints showed little tenderness as well as swelling over the PIP as well as DIP joints. There was no restriction of movement of the joints in the hands. With this picture, we thought it could be probably arthritis for further diagnosis, for further evaluation, and hence we made this as a provisional diagnosis. When we evaluated him, the whole of arthritis panel was negative, including his rheumatoid factor, which was negative, as well as anti-CCP was negative. His X-ray, both hands, was completely normal. Since he gave some history of increase in pain when he ate certain type of food, we had done his serum IgE levels as well. His serum IgE was on the higher side. It was 570 international units. And further moving on to allergy panel, here the food panel showed positivity to chicken as well as egg, and the inhalant panel showed sensitivity to the house dust mite, which was strongly positive, that is class 5. Hence, a diagnosis of allergic diathesis was made, and he was started on sublingual immunotherapy and antihistamines, and he responded dramatically to the treatment within 3 months. And he was also asked to avoid non-veg food, especially for a few years. And his pains have subsided, and he is on regular follow-up. So this was a case which was suspected to have arthritis, which turned out to be allergic diathesis. Moving on to my last case. Here, she is a 42-year-old lady from Bangalore who came with the history of multiple joints pain since 8 months and history of recurrent sneezing episodes, swelling of face, eyelids, itching and redness of both eyes since 1.5 years, and she also complained of wheezing since 8 months. The joint pain history in detail, it was a symmetrical joint involvement involving both hand as well as foot joints. It was associated with swelling, and there was early morning stiffness lasting for an hour. Pain was relieved during work, and it was increased when she took rest. And she was working in a private sector. Her past history, she was an epileptic since 17 years, and she was on carbamazepine BD dosage. And treatment-wise, whenever she presented with multiple joints pain and allergic symptoms, she had taken symptomatic treatment, that is antihistamines and analgesics, as well as rotacaps for her wheezing. Her obstetric history, she had regular menstrual cycles, married life of 15 years, she did not have any children. Personal history, she was a non-vegetarian by diet, she had normal appetite, bowel bladder habits as well as good sleep. There was no pallor, icterus, cyanosis, lymphadenopathy except for the edema which was positive, and vitals were stable. Systemic examination was completely normal. Her joints examination revealed both the hand joints as well as feet joints. There was tenderness as well as swelling without any restriction of movement. With this, a provisional diagnosis of arthritis with allergy was considered. And when we did the investigations, her eosinophil count was on the higher side, 12.8%. Her rheumatoid factor also was borderline elevated, that is 22.7. Her anti-CCP was significantly positive, 42. Serum IgE levels was high, 373. AEC, that is absolute eosinophil count, was 600. Her X-ray, both hands, showed juxta-articular osteoporosis, and allergy panel, food panel showed positivity to apple, mustard and coffee, and inhalant panel, she was sensitive to house dust mite, wool as well as cat epithelium. So hence here a final diagnosis of rheumatoid arthritis with allergic diathesis was made. She was started on methotrexate, hydroxychloroquine, sublingual immunotherapy, and NSAIDs and antihistamines were given on required basis along with calcium and vitamin D supplements. Her arthritis has subsided, her allergic symptoms also have come down gradually, and she is on regular follow-up. So this case had both symptoms of allergy as well as arthritis on presentation, and was finally diagnosed with both rheumatoid arthritis as well as allergic diathesis. Coming to the discussion slides, these were the varied presentations of allergy which turned out to be autoimmune conditions as well as neoplasms. The concomitant presentation of these conditions and the common mechanism in some of the cases could be explained by looking at the key elements which are involved in the immune response in both allergic as well as autoimmune conditions. These key elements are the mast cells, the antibodies, the T cells, cytokines, and the genetic determinants. The parallel appearance of allergic as well as autoimmune conditions in some patients may reveal that such aberrations of the immune system may have a common pathophysiologic mechanism. Moving on to the key elements, the mast cells, which play a key role in allergic reactions, and the wealth of inflammatory mediators they express, make it likely that they have profound effects on many autoimmune processes as well. Coming to the cytokines, the activation of protein kinases by inflammatory cytokines and the environmental stresses both put together may contribute to the allergic as well as autoimmune diseases. And coming to the T cells, because of the central role the T cells play in the immune reactivity, the T cell receptor loci have long been considered as an important candidate for common disease susceptibility within the immune system, such as asthma, atopy, and autoimmunity. So here, immunomodulation is the key to successful treatment of allergy as well as autoimmune diseases. The IgE antibody, it is an evolutionary conserved member of the Ig family, and it has highest determined affinity to the receptors and antigens among all the antibody classes. The IgE antibodies, they not only engage the cell surface, they also act on the Fc epsilon R1 receptor as well as the CD23 also, and they activate several cell lines, and they activate all these cell lines against the tumor cells in vitro. And the solid tumors are associated with inflammatory responses involving the infiltration of not only the B cells, the T lymphocytes, the neutrophils, and the natural killer cells. There are also mast cells and macrophages and eosinophils expressing these IgE receptors, which come into picture when a tumor is present. So coming to review of literature, there are many papers about this topic, that is allergic disease and autoimmune effector pathways. One such paper says a multicentric approach to immunologic tolerance induction are being taken, and these approaches could be the interference with co-stimulatory signals in T cell induction, TCR antagonism by altered peptides, exploitation of antigen-induced apoptosis to eliminate the undesired T cells, and opposition of inflammation by induction of regulatory cytokines, and induction of transplant tolerance by mixed chimerism, and so on and so forth. So a mixed approach and a research on these probably could help us understand better in both allergy as well as autoimmune pathways. And coming to a review of literature on IgE levels as well as cancer, there are many papers which are suggestive of high IgE levels where there is lymphoid malignancies, especially the CLL, multiple myeloma as well as Hodgkin's lymphoma. So to conclude, the notions presented above, they open up a new interesting therapeutic perspectives for the prevention of both allergic as well as autoimmune diseases. Induction of long-term antigen-specific immunological unresponsiveness holds great promise for treatment of many immune-mediated diseases like asthma, allergies, and autoimmune diseases, as well as transplant rejection. Unlike the current immunosuppressive treatments, immunologic tolerance therapies would affect only the undesired immune responses, leaving the protective immunity intact. We hope to gain a better understanding of how the immune system changes in patients with autoimmune diseases and cancer as well as allergic patients. So finally, the take-home message here is allergy can mimic various diseases like malignancy, autoimmune problems, as well as immunodeficiencies. Malfunctioning of the immune system can happen in three major conditions: allergy, autoimmunity, as well as immunodeficiency. There can be switching over of Th1 response to Th2 response, or vice versa, and even T17 responses, and everything can coexist together. And immunomodulation as well as tumor appropriate regime is the mainstay for successful treatment of allergic, autoimmune diseases as well as neoplasms. These are few of my references. Thank you, everyone. I would like to extend my heartfelt thanks and gratitude to Dr. Chandrasekhar sir and Dr. Renuka ma'am for providing me this opportunity to share my experience with all of you. Thank you, one and all.